Well, great. It's a real pleasure for me to be here, and I'm actually going to proceed in three parts today. The first is because Brad challenged me to share some information about Bioview. I'm going to do that. The second thing is that I was actually asked to talk about liability issues, so I am going to do that. And then the final thing I'm going to do is talk about current policy conflicts that I think are going on between OHRP, the ANPRM, NIH, and a number of other organizations that leave us in quite a bit of a pickle in knowing how to move forward. So first about Bioview. We've done a lot of things to sort of assess the acceptability of Bioview, and I'm going to mention some of them to you, in addition to the many focus groups that we did going back actually to the year 2000 and going forward until as recently as about 2010. We also routinely survey our patients at Vanderbilt about their views about Bioview and the acceptability of it. We do have a community advisory board that meets periodically. I will tell you that in our surveys, our patient population in general is really quite accepting of Bioview and thinks it's a good idea. But what I want to tell you about here are two studies. The study that is on, I'm right, left dyslexic, on your right, up here is this one. We did a population-based survey in Nashville where we went out using a sociologically determined frame, heavily oversampling for minorities and other people. We interviewed them about a variety of issues, not the least of which is Bioview. The one on your left is a survey that we did of Vanderbilt faculty and staff. Our response rate was about 20%, but on the other hand, we got about 4,000 responses, so it's a really big number. And what I want, and these are data from a study that was published in 2011 with Kyle Brothers as the first author. And what I want you to see here is that when we asked people what they thought about a de-identified data bank, you know, the fact of the matter is both groups were really pretty fine with it. Greater than 90% thought it was fine using a DNA identified with all identifying information removed, so long as people can opt out. We asked a question about, even without the opt-out, still around 90%, 88% in the community, 93% among the faculty and staff. And we ask about the role of review by an IRB and whether that helped. And again, in both groups, it was really pretty popular. Now, I will tell you one thing, that in our faculty and staff survey, the only thing that we asked that determined people who weren't happy with Bioview were people who got their health care outside of Vanderbilt. My hypothesis going in was that faculty were going to be much more ornery about this than staff were. It was actually the same across the whole university. So we had a really pretty high acceptance in both of these surveys. So I just want to point that out to you. The next thing we did, and this is in the community group, we actually asked them whether they trusted Vanderbilt in keeping medical information and research information and DNA private, and all the numbers in red are the answers, and they're all around 90% or higher. So there was a good bit of trust in the community. That was really fascinating because when we did our initial survey focus groups in 2000, there was less trust of Vanderbilt at that time, but now there's actually really quite high acceptance of Vanderbilt in the community, which was, I think, really good news. I also want to mention that, that we did a similar study in the eMERGE consortium. Gail has already looked at this. And in this case, we were asking what people thought about data sharing. And what we found here was that, in general, people were really pretty content with data sharing. In Marshfield, One person out of 12,500 opted out of data sharing. That's pretty low opt-out rate. Vanderbilt, about 88% were either neutral or said they actually thought data sharing made them happier to contribute to research. In Group Health Cooperative, they reconsented their population group and for data sharing because their initial consent form said they weren't going to share data, and 80% of them actually consented to data sharing on a reconsent. They did express some concerns, but I just want to put that out there that that we're really, well, I'll just say a lot of this research, and I'll come back to this as toward the end of my comments, a lot of this research is affected by how you ask the question. If you ask them, are they worried about whether things are going to be, whether their information is not going to be private, if you ask them whether they think this research is risky, then you're going to get the answer that they think this research is risky. If you ask them whether they think this research is a good thing and whether they like the biobank and think this is a good thing for the institution to do, at least in our case, the answer is emphatically yes. And it's been emphatically yes now for 7 or 8 years at Vanderbilt. So I just want to put that out there. Now I want to say a little bit about liability. And I'm going to make a distinction here about, well, first of all, I'm going to make a couple comments about the President's Commission report on anticipate and communicate. And actually also about the ACMG. This particular field is just fraught with with language that's confusing about what we're talking about here. So I'm going to be really clear what I'm talking about here. With regard to returning individual research results, it makes the most sense when you are talking about a research result that is the purpose of the research. If you are, in the case of cancer, which is of course the topic of this conference, if you are doing cancer genetic testing in order to find out a particular variant that's going to help with prognosis or directing therapy, that's exactly the kind of research that it makes most sense to think about returning, even though there's an ongoing debate about the extent to which CLIA applies or not. And I would just raise to you that just in the last couple of weeks, there has been a question raised about whether returning research results may actually create liability risks if you return inaccurate results. Basically based on the fact that many of the current databases are not well curated, are not very accurate, and that it's entirely possible that people will get results back that in fact on later investigation are found not to be particularly accurate. So the liability risk here is probably returning a result that turns out on later investigation not to be accurate. Okay. The real action, or where most of the debate has been about variants that are not the target of the research. And here I think, and here Gail talked about what I think is a really important issue here. One of them are non-targeted findings that were, quote, stumbled on in the course of research, which are not a very large group, but which are something we need to think about. Another issue that we need to think about that hasn't really gotten the attention that it needs are pleiotropic effects. This is particularly true in the area of pharmacogenetics because most of the drug metabolizing enzymes actually affect a lot of different things. And so I think we have to look at pleiotropy. We have to look at the things that we're stumbled upon here. These, I think, are really the so-called incidental findings, and there really aren't very many of them. And as Gail pointed out, that if you actually do research the way like people like her and like most of you do, you're only going to find a very limited subset of things. And the only question that you have to ask there is, among those things that you find, which ones are these are the stumbled upons or the pleiotropic effects. I want to make the point with regard to the liability issue that, that to affirm Jeff's point. The risk of liability for returning incidental findings, things that you stumble on in the course of research, is actually really quite low. I did a very extensive study about a year ago looking at, and this is in the clinical setting, not the research setting, and what we did there actually are no reported cases having to do with failure to return incidental findings in genetics, none. We looked in radiology, which is the other area where this has been discussed a lot because it's a complex test that can reveal a lot of things. There are 8 reported cases. And in most of those, and actually only in 1 or 2 of those, was there any basis for liability. So let me talk like lawyers talk and say, so what are the elements of liability for failing to report something? One is there a duty to the patient? And so sometimes, and that's a very real question about whether a downstream investigator has the same level of duty to a patient participant as the treating clinician does. And in some cases, even in the clinical context, they found that a physician didn't have a duty. The other thing is that you have to show, another thing you have to do is show a breach of the standard of care. And in many of these cases, what they found was that the result that was found, that failure to identify it or disclose it did not breach the standard of care. And then there was another article that Amy McGuire and I wrote that appeared in Genetics and Medicine a couple years ago, and making the point that the duty of care within the research context, the bar ought to be considerably higher than it is in the clinical context. So I've just made the case to you that there's very little litigation in the clinical context about incidental findings. And if you think about it, there have really only been 2 major cases having to do with any sort of legal liability in the context of the research. Neither one of them are even either remotely pertinent here. And so what I would argue is that anybody can walk into the courthouse. I'm here to tell you that so long as you have a filing fee, anybody can walk into the courthouse. That's the truth. But if you're going to get representation, then there has to be a really pretty good chance that you're going to prevail in your litigation. And I will tell you that the basis for liability in the context of litigation for failing to return individual research results is really probably pretty low. So maybe it'll change. Gail's already talked about this, but I'll just say something a little bit more about it. There's increasing consensus that there is no duty to hunt in research for variants beyond the targeted genes. No duty to hunt. This is both the Presidential Commission for the Study of Bioethical Issues, also the paper that Gail referred to that will be submitted shortly. And what I would say here, and both of these explicitly reject the ACMG clinical recommendations. I would also say that that the Presidential Commission, in my view, is actually too deferential to the ACMG recommendations. There has been a lot of complaint about, or a lot of criticism of the ACMG recommendations and their duty to hunt. So I just want to put that out there. But what I really want to say here is that these statements really call into question some of the proposals that have been put forth earlier about obligations to return results, and talking about obligations of downstream investigators, obligations of biobanks to follow up data for a very long time, to go back and re-examine data periodically. None of that is founded in medicine. None of that applies to clinical practice. And so I think we need to be very careful about some of the proposals that are out there about exactly how far liability ought to, or be there ethical obligations or risk of liability in the context of returning research results. I will say that there is clear consensus that there needs to be informed consent if we're going to be returning research results. I think there's no doubt about that. Gail is exactly right that it's important to tell people at the front end that let them know that that may happen, rather than going to them after the fact and saying, oh, by the way, I know something important about you. Do you want to know it? That's really not okay, either ethically or legally. And if this was not disclosed, I think this too raises the bar for the impact of the scope of disclosure and the impact of unwanted disclosure. But what I also want to raise here is that why I think we are rushing headlong into an idea of return of results in research findings. I think we need to be really very cognizant of its impact on research, to which I am, and that we need to, if we're going to do it at all, we need to be very narrow about it. We need to talk about it at the front end and be very cautious about how we proceed. Now I'm going to say some thought about broad consent for research and data sharing, and that I will close up for that. I want to thank Holly for making some comments about the ANPRM, a document that I believe is deeply flawed in a variety of ways. And now I'm going to share another one for you. The ANPRM, at the same time, by the way, that it excludes virtually all social science research with adults, decides that consent is needed for all uses of biospecimens because DNA is identifiable per se. And I have to tell you that, and this again alludes to Brad's comment, yeah, you can re-identify DNA if you have world enough in time and all the money in the world and all the desire in the world. And so that I think is an issue. But what I think is more of an issue is that clinical data is much more identifiable than DNA. If I were on an airplane, which I am from time to time, and if I had a choice between leaving my de-identified medical record on the plane or leaving my DNA on the plane, I can tell you which one I would worry about. And it ain't the DNA, okay? And so, so I think that if what really makes this business about requiring consent for all use of biospecimens is that it's, quote, identifiable, then it means that we have to have consent for all clinical data. All clinical data. That's the death of epidemiology. That's the death of an enormous amount of research, which has conferred great contributions to our clinical knowledge. It has got to be the wrong answer, and that what the ANPRM's recommendation is based on is unwarranted and unfounded genetic exceptionalism. And so I think we have to look at what the real risk of re-identification of genetic information is, and the answer is it isn't very high, and the response to it has got to be that what we have to do is pay more attention to creating systems of oversight and control, and not just saying that, well, we're going to do informed consent and then just let it go. The ANPRM also says that it favors broad consent for research. As they say, a standard brief general consent form allowing for broad future research. They give us exactly no idea what that means. Zero, not any. But one thing they do say is that this applies only if we're not going to return results. So if we are in fact going to return results, then this is completely meaningless. This is completely meaningless. The NIH recently put out a data sharing proposal that, in my view, is premature. This came out in September of last year. They said that basically broad consent for research and data sharing is a factor to be considered by NIH in awards with few exceptions. I think that that means that the way I read that is that if you don't have broad consent for data sharing and broad research, then you're not going to get your money. So that, I mean, that's the way it reads to me. So just saying. And what I think is sort of ironic about this is that many of us, including Gail's group and my group and many others, 10 groups as part of the eMERGE consortium, were recently funded by the NIH to actually look at the acceptability of broad data sharing. And we're going to be doing a survey of 16,000 people to ask them about the acceptability of broad consent for data sharing and broad research use. I will tell you that we are in the final stages of a systematic review in looking at patient participant stated desires for control over research use and their willingness to accept broad consent. And I'll tell you what our tentative findings are. First of all, there's not a huge amount of data in this area. But the second thing to say is that there is wide variation in this area, and that it depends a lot on how you ask the questions. So the study that is cited most widely in this area is David Kaufman's study, in which you see that the overwhelming majority of people want research results back. Well, let's talk about what that particular prototype was. The study that he was talking about there was one in which individuals were going to be enrolled in a longitudinal study in which they had periodic physical examinations, periodic recontacting for updates, and other interventions of that nature, something a la Framingham, okay, only with biospecimens. Now, you can imagine that in a broadly interventional study like that people would probably say, yeah, I want something back. Whereas in other studies like ours, where we use de-identified residual blood specimens and de-identified medical records, that there is considerably less contact and considerably less intervention for that. The other thing that is really difficult in this systematic review is that, for the most part, these investigators don't publish their survey instruments, and so it's really hard to tell how they asked their questions and why they got the answers that they got. So I think what we really have to look at here is we've got to ask the right questions, and we've got to know how they were asked. We've got to ask whether, we've got to ask whether broad consent for data sharing is acceptable, which is what we're being asked to do, or whether people, given all the time in the world, all the resources in the world, want total control about information about them. I mean, it depends on how you get the questions. So I'm just saying that this is a major issue going forward. So my conclusions are that embracing return of results in research is going to increase the potential for liability, particularly since some of the current databases are not all that good. Maybe once ClinSeq is done, we'll be in better shape. What people should be protected from is the unwarranted re-identification of all research data. And that really the action here is not so much in what they give consent to, but rather what our oversight, accountability, transparency, limitations on downstream uses, et cetera, et cetera, et cetera are. That is where the rubber really hits the road, and we should be paying much, much, much more attention to that. And I think, and my own view is that broad use and data sharing are highly desirable. I'm a huge fan of this, but I think questions still remain about acceptability. Thank you very much.